Bronchiectasis. The definition of bronchiectasis is chronic irreversible dilation of bronchi and bronchioles. So, in bronchiectasis, what happens is there will be chronic irreversible dilation occurs where bronchi and bronchioles. And this is irreversible, it cannot be reversed, and it affects the bronchi and bronchioles. In this picture, you can see healthy airway and bronchiectasis airway. So, in healthy airway, it will be small and there is no mucus production. But in bronchiectasis, the airway is dilated very much, then the mucus production is excess. So, that is the bronchiectasis. Next one, etiology of bronchiectasis. The etiology is divided in focal and diffuse etiology. Focal means due to obstruction, mainly due to tumors or foreign body, the presence of foreign body that may leads to gradual dilation of bronchi and bronchioles. That is known as the focal obstruction or focal etiology. Next one, diffuse etiology. In diffuse etiology, there will be infection, especially the bacterial, non-bacterial and mycobacterium etiology. Then immunodeficiency. In case of HIV, bronchiolitis obliterans after lung transplantation, then hypogammaglobulinemia, all these conditions, the person will have the immunodeficiency. Next one, genetic causes. Genetic causes include cystic fibrosis, Carthagener's syndrome, alpha antitrypsin deficiency. These conditions that cause bronchiectasis. In Carthagener's syndrome, here it's a rare condition. It affects the ciliary tract, especially the fallopian tube and the respiratory tract. So the increased production of mucus and the problems will be occurs in the respiratory as well as the reproductive system. Then cystic fibrosis, there will be accumulation of mucus production. Okay. So, in next one, autoimmune disorders. Autoimmune disorders or the rheumatologic disorders. Here, the example is rheumatic arthritis or rheumatoid arthritis. Next one, Sjogren syndrome. Sjogren syndrome also a autoimmune disease. Here, our normal cells affected by our own body cells. So, there will be inflammatory response. Then recurrent aspiration or the recurrent respiratory tract infection may cause the bronchiectasis. Then miscellaneous causes, it includes the yellow nail syndrome. Yellow nail syndrome, it's a very rare condition. Here the our nails will be yellow shape and yellow color and curved in shape. And here it affects the respiratory tract and the mucous membranes. That's why it affects the lung. Then traction bronchiectasis from post radiation. So after radiation there may be chance for the bronchiectasis due to irritation, chronic irritation. Then IPF, that means idiopathic pulmonary fibrosis. Then idiopathic causes, that means unknown causes. There are four types of airway dilation. That is known as the rates classification. So, rates classification is associated with bronchiectasis. So, mainly cylindrical, tubular, varicose and cystic are the classification of bronchiectasis. Cylindrical, tubular, varicose and cystic. It is known as the rates classification. Here the cylindrical, it affects the medium sized bronchi. So it is in cylindrical in nature and it affects the medium sized bronchi. And varicose, the name itself, it is tortuous in nature, right? So it will be appear as a tortuous appearance and there will be dilation of bronchioles. Then cystic otherwise known as the saccular, it affects the larger bronchi and it appear as a sac-like structure. So that is the classification of bronchiectasis. Cylindrical, it is otherwise known as the tubular form. Okay, in previously I said that cylindrical and tubular, it is not separate cylindrical or tubular. It is the most common form of bronchiectasis. Next is the varicose and cystic. So the three forms of bronchiectasis: cylindrical bronchiectasis, also called tubular bronchiectasis; varicose bronchiectasis, otherwise known as the fusiform bronchiectasis; then cystic bronchiectasis, otherwise known as the saccular bronchiectasis. Next is the pathophysiology or the pathogenesis of bronchiectasis. Here, due to etiological factors, there will be bronchial insult that leads to inflammatory response in the bronchi and bronchial mucosa. That leads to weakening of the bronchial walls and loss of supportive structures. So here there will be accumulation of thick sputum secretions that leads to the impaired mucociliary clearance. So due to the production of thick sputum, there will be impaired mucociliary clearance that leads to bronchial obstruction. So in the bronchial obstruction, that leads to the further inflammatory response, and that leads to scarring or the bronchial damage will be occurs, and this bronchial damage that leads to the bronchiectasis. So here there will be fibrosis and scarring and dilation of the bronchial wall occurs, and the lung tissue will be replaced by the scar. So that is the pathophysiology. Due to the etiological factors, there will be inflammatory response, and due to the inflammatory response, there will be weakening of the bronchial walls and the loss of supportive structures. So that leads to production of mucus secretions, and that will leads to the impaired mucociliary clearance that leads to the obstruction, and this obstruction further leads to the inflammatory response. Then at last all these things leads to the bronchial damage and further scarring and dilation of the bronchioles. That is known as the bronchiectasis and the clinical features. The main clinical features can be seen in bronchiectasis include cough with sputum production, and the sputum will be very thick and tenacious in nature. Hemoptysis can result from airway neovascularization and rupture. So hemoptysis means blood in the sputum, and it is common due to neovascularization. Lung crackles, rhonchi and wheezing. When we are auscultate the chest, you can hear the crackle sound, rhonchi or the wheezing sound. Then when you are observing the digits or the nails, you can see the clubbing. Then there will be exacerbation features. There will be worsening of symptoms greater than 2 days. Then require treatment suddenly or immediately. Then if we delay the treatment, there will be further damage to the bronchial layer. Then there will be dry bronchiectasis associated with non-tuberculous or mycobacterial infection. Due to mycobacterial infection, there will be dry bronchiectasis. There will be less sputum production here. So actually the wet bronchiectasis also present, dry bronchiectasis is there. Uh, Wet bronchiectasis is the common and dry bronchitis is usually associated with the mycobacterium infection. The main complications associated with bronchiectasis is hypoxemia, pulmonary hypertension and the right heart failure. The diagnosis of the bronchiectasis include clinical history, physical examination, lab testing, especially the complete blood count, TCDC, sputum culture, X-ray chest, HRCT thorax, imaging modality of choice, especially the airway dilation can be seen, lack of bronchial tapering will be seen, then bronchial wall thickening can be observed by HRCT. Then we have to find out the focal etiology, that is foreign body or the tumor, the presence of tumor in the uh, respiratory tract. This is the X-ray of bronchiectasis patient. So the red arrows shows that there will be dilated bronchi and bronchioles. So in the red arrow, that indicates the dilation of bronchi and bronchioles. This is the picture of X-ray. But in case of HRCT or the CT scan, we can easily identify the dilation. This is the picture of bronchiectasis patient CT. So here we can easily identify the dilated bronchi and bronchioles. So the red arrow represents the dilated bronchi and bronchioles. Then bronchoscopy, usually the source of secretion, the collection of the microbiological test for collection of sputum for microbiological test, we are doing the bronchoscopy. Then sputum culture in order to identify the microorganism. Then pulmonary function test, the pulmonary function test we are usually doing in order to identify the functional capacity or the vital capacity of the lung. Then a spirometer also we are assessing, then the complete blood count. The management of bronchiectasis include the main problem in the bronchiectasis is the dilation of bronchi and the production of excess sputum. So the high sputum burden or difficulty in expectorating, that will be reduced by giving mucoactive agents. Then concomitant asthma and COPD have to be treated with medicines. Then treatable underlying causes, it should be treated. Then new pseudomonas aeruginosa, in that conditions antibiotics have to be started for eradication. Then frequent or severe exacerbations we have to give with macrolides or the inhaled antibiotics also can be given. Then another management we have to do is airway clearance, smoking cessation, vaccination of Haemophilus influenza. Then sputum cultures, based on sputum cultures we can give the antibiotics. Then pulmonary rehabilitation, then chest physiotherapy, then postural drainage. All these are useful for the bronchiectasis. Then bronchodilators can be given and nebulization can be given, and then expectorants also can be given. So these all are the management measures we are used for bronchiectasis. And surgical correction or surgical management for bronchiectasis can be done if the failure is occurs. So there are some conditions for starting surgical management. We can see that the first one, failure of optimized medical therapy for 1 year. Second one, severe or frequent exacerbations. Third one, treatment of complications such as empyema or lung abscess. Then localized lesions to avoid sepsis and extensive lung damage. then bronchiectasis distal to tumors, then recurrent refractory or massive hemoptysis. So all these conditions we are doing the surgical management, especially the lobectomy, pneumonectomy can be done. So mostly surgical management we are doing as a final treatment. We can't save the patient without this surgical management. Then only we will do the surgical therapy for the bronchiectasis patient. Maximum we will control the patient with the medical treatment. Okay, surgical management is the last choice, especially if the failure is occurs and the person have severe a big tumor along with the bronchiectasis, then frequent exacerbation or extensive lung damage. All this condition only we are doing the surgical management. So in this class we have seen what is bronchiectasis, the definition, that is chronic irreversible dilation of bronchi and bronchioles. Then we have seen the etiology of the bronchiectasis, especially the focal and diffuse etiology. Then types of bronchiectasis, especially the cylindrical or the tubular, then saccular or the cystic, then varicose or fusiform. Then the pathophysiology we have seen. Then clinical features, mainly the thick sputum is the main clinical feature of bronchiectasis, along with the dilation of bronchi and bronchioles. So due to that there will be dyspnea, hemoptysis, clubbing of fingers, fatigue, weight loss, tachypnea, tachycardia. All these features can person will exhibit. Then diagnostic measures, same as history, physical examination, CT scan, then radiography, the chest x-ray or radiographic findings. Okay, then bronchoscopy, sputum culture, pulmonary function test. All these are helpful for the diagnosis of the condition. Then management, mainly we are doing the management to reduce the sputum production. Then in case of infections, we are treating with the antibiotics based on the sputum culture. Okay, then we are doing conservative management, especially the cessation of smoking, then uh, the vaccination for Haemophilus influenza, then expectorants, bronchodilators, antipyretics, antibiotics, then mucolytic agents. All this will be administered.